Hi, Denise and I have no disclosures to report. We will be going over the following objectives. First, we'll discuss the side effects of various medication classes that could impede a patient's progress with diabetes remission. Next, we'll compare and contrast the varying considerations that impact deprescribing within each diabetes medication class. We will describe subjective and objective measures to be included in the assessment and planning of medication deprescribing, and establish optimal self-monitoring frequency and develop a patient plan for adjusting medications based upon self-monitoring results. Lastly, we will identify the type and frequency of follow-up, monitoring, and patient interaction options for optimal medication deprescribing.
Thanks, Dr. Shull-Clayton. Next, I'd like to show a bit of a spin on a treatment algorithm you might have seen in the past from expert guidelines from traditional medicine's approaches to treating type 2 diabetes. This guidance generally discusses and assumes progression of disease, giving direction on which medications and how many medications should be initiated in relationship to the current A1C lab values. As we're talking about medication deprescribing and the remission of diabetes, let's turn this traditional algorithm around. We don't have enough evidence at this time to give succinct and specific instructions, but we can tell you that disease remission is possible. What if we thought about this in a different way? Perhaps in a patient with an A1C value greater than 9%, we'd want to consider intensive lifestyle medicine treatment as compared to a patient that's got an A1C value greater than 7.5% but below 9%. We might be able to work with this patient on therapeutic lifestyle changes as an outpatient. Patients with an A1C value of less than 7.5% may only need education, as studies have shown that patients meeting with certified diabetes care and education specialists can realize an A1C reduction by a percentage of 1. Even with basic diabetes education, patients with A1C values of less than 7.5% can experience reductions of A1C values to lower than 6.5% without the addition of medication, which would be termed diabetes remission. As we work towards medication deprescribing, our goal is to move patients from that A1C of greater than 9% to a more controlled A1C, while we are removing or reducing medications with lifestyle treatments that focus on the root of disease rather than adding medications. Our ultimate goal would be diabetes remission.
We want to look at medications that cause hyperglycemia, as this will impede their progress in diabetes treatment and reversal with lifestyle medicine. Common medications that will do this are beta blockers, statins, thiazides, and thiazide-like diuretics. Other medications to consider are fluoroquinolone antibiotics. These are usually short-term, and so for more patients, this should not be a problem. Other medications like antipsychotics are chronic medications and should be part of the discussion when looking at what medications could impede a lifestyle medicine treatment. Another is corticosteroids. These could be short-term or long-term medications and could also impede progress in diabetes treatment. Calcineurin inhibitors and protease inhibitors are the last two classes that could cause hyperglycemia and make it more difficult for patients to treat their diabetes with lifestyle medicine alone. Medications that inhibit nutritional change. Some medications often used to treat patients with diabetes can actually inhibit their lifestyle changes and make it more difficult to eat a whole food plant-based diet. Why is this? Well, often these medications work to lower the appetite or decrease the rate at which blood glucose is released into the bloodstream. Medications that have action similar to this are biguanides, glucagon-like peptide 1 agonists, dipeptidyl peptidase inhibitors, thiazolidines, alpha-glucosidase inhibitors. Some patients may feel uncomfortably full when they're eating the amount of fiber needed in a whole food plant-based diet while on one of these medications, so it might be helpful to consider tapering them down as patients make the switch. Other medications that can inhibit nutritional change include sedatives, some antibiotics, mostly the ones that have gastrointestinal side effects, immunotherapy, which often causes progressive diarrhea and gut cell loss, Chemotherapy, which also impacts the lining of the gut and causes diarrhea, cell loss, anti-epileptic medications, and anticoagulants. Anticoagulants, we mentioned here, because often they can need a dose change based on the types of foods that people are eating. We recommend, just as an expert opinion, that you have patients eat a regular amount of leafy greens or foods with vitamin K, and then taper the Coumadin in particular to match the amount of those healthy foods that they have in their diet, instead of telling patients just to avoid those foods altogether. Medications that inhibit physical activity include the DPP-4 inhibitors, which can cause severe joint pain, medications that can cause dizziness or lightheadedness, like beta blockers or SGLT2s. Statin drugs are commonly known for myalgias. These medications you may want to consider tapering down or discontinuing if patients are having a difficult time being physically active because of one of these side effects. Next, we'll talk about medications that inhibit sleep. So sleep is an important part of lifestyle change, weight loss, and lowering disease risk. Medications for hypertension can inhibit sleep. These include clonidine, diuretics, and beta blockers. Corticosteroids can be very stimulating, also inhibiting sleep. And common cold and cough medications, especially those with alcohol or sedating antihistamines, can cause problems with sleep as well. Headache and pain medications that contain caffeine, because the caffeine will be stimulating. Nicotine replacement medications, because nicotine is stimulating. SSRIs for depression and anxiety can cause either sedation or patients to be more active or hyper. And stimulants, those often used to treat attention deficit disorder or narcolepsy. For obvious reasons, these medications are used for their impact on alertness and attention and focus, and so they will inhibit sleep. Thyroid hormone medications will also do this, especially if at a high dose or at a dose where symptoms of hyperthyroidism are apparent. And lastly, antiarrhythmic medications. Medications that inhibit stress reduction include the following classes: corticosteroids, caffeine, L-DOPA, which is used in Parkinson's disease, thyroid hormone medications again, nicotine replacement medications, stimulants, asthma medications, and decongestant medications. These medications are often stimulating and can cause anxiety symptoms in patients. Medications that inhibit weight loss include classes such as anticonvulsants, anti-migraine, neuropathic pain like gabapentin or Lyrica, antidepressants and anxiety medications, and mood stabilizers. Other classes include antihypertensive medications, and the three listed before: beta blockers, calcium channel blockers, and alpha blockers, antihistamines, antipsychotics, and some of the diabetes medications, including insulins, sulfonylureas, thiazolidines, and meglitinides. Opioids and steroid hormones are also on this list. If patients are on some of these medications and having a lot of trouble losing weight, it may be worth looking into seeing if there are other options that they could be on, or if they could increase lifestyle medicine treatments to replace one of these medications.
Hi, this is Dr. Fields, and next we're going to be moving on to our second objective, and we're going to compare and contrast the varying considerations that impact deprescribing within each diabetes medication class. So our first category of medications are our biguanides, which includes metformin, immediate release, and extended release. You can see here the different formulations available of metformin and the different dosages that are available commercially.
So we review metformin in this discontinuation profile. There are some points of interest.
So our first category of medications are our biguanides, which includes metformin, immediate release, and extended release. You can see here the different formulations available of metformin and the different dosages that are available commercially.
So we review metformin in this discontinuation profile. There are some points of interest to consider when deprescribing medications. There really is a low risk for low glucose events if metformin is being used alone in therapy. The biggest risk in using metformin with lifestyle treatment is the gastrointestinal side effects that can occur in some patients. This may not be a mild gastrointestinal upset, but for some patients that are really impacted by this side effect, it can be a significant stomach cramping or frequent episodes of diarrhea.
I've had patients experience 7 to 8 loose stools each day while on metformin. I've also had patients in which we had to pursue a metformin taper or discontinuation after discovering the patient was having to take a change of clothes with them whenever they left their house, as diarrhea might come without any warning. We should be assessing for this impact on a patient's quality of life. Even in less severe cases, lifestyle treatments may be impacted as the gastrointestinal side effects could be preventing patients from eating an adequate volume of food with the transition to a whole food plant-based diet. And the side effects could be preventing your patients from exercising if they're afraid they might have a loose stool when they go out for a walk. Another side effect that can occur with this medication is a reduction in vitamin B12 levels, as long-term metformin therapy is known to reduce intestinal absorption of vitamin B12 and folate. The American Diabetes Association recommends periodic assessment of vitamin B12 levels for patients on metformin therapy. This medication has a low cost. It's fairly easy to administer as an oral medication. In these slides, we're going to be focusing on patients undergoing outpatient, non-intensive therapeutic lifestyle change. Later in this presentation, Dr. Scholl-Clayton will be providing you with options for the frequency in which you might assess these patients and how much more quickly you might need to taper if patients are in an intensive therapeutic lifestyle program or an immersion program. But for the purpose of these general slides, we're going to be assuming outpatient, non-intensive therapeutic lifestyle change, and thus we're going to be looking at follow-up assessment of a patient's self-monitoring glucose levels at a weekly frequency. The dose frequency for this medication is typically twice daily for the immediate release formulation and once daily for the extended release, although you might encounter patients who take the extended release formulation in a divided dose spread over 2 to 3 times a day to lessen the gastrointestinal discomfort that can occur. You can discontinue abruptly if it's an intensive program or in patients where the gastrointestinal side effects are preventing the patients from making prescribed lifestyle changes. If the patient is using the 500 milligram or 750 milligram formulations while undergoing outpatient non-intensive lifestyle treatment, you can reduce by 500 milligram or 750 milligram increments respectively as needed. Or you can taper more aggressively if you can see through the assessment of a patient's blood glucose self-monitoring data that this is needed. With the 1,000 milligram formulation, I would consider assessing at the onset of lifestyle changes what kind of supply the patient has at home so you can convert them to a 500 milligram formulation as they use the last of the 1,000 milligram tablets, as this will give you more flexibility with the dose de-escalation. You will also want to consider and identify if your patient is getting metformin in a combination tablet that's combined with another diabetes medication, such as sitagliptin with metformin that's combined into one tablet. You may want to consider prescribing the 2 individual medications in place of the combination medication to, again, provide more flexibility in deprescribing with lifestyle change. The next category that we'll be looking at will be the glucagon-like peptide 1 agonists. You can see here the generic names, the exenatide, extended release, and I'm not going to read all of the names on the side, but these are the ones that are commercially available today. All are only available in a brand name. As we move on to review the discontinuation profile for the GLP-1 agonists, it's a low risk for causing low glucose events. The way in which these medications work, they only activate the release of more insulin when your blood sugars are elevated. So as monotherapy or when used with other medications that are low risk, this should not be a concern. The most prevalent adverse effect, which could impact lifestyle change with this medication, will also be gastrointestinal. This class will cause more nausea and vomiting due to slowed gastric emptying, but may also cause diarrhea in a small percentage of patients. These side effects can inhibit success with a change to a whole food plant-based diet because as it slows down the digestion of food from a meal, it may limit the volume of food that the patient can eat during a meal. This effect is also one of the reasons that the expansion of use for this class of medication has led to weight loss indications. With a whole food plant-based diet, we do need our patient to eat a larger volume of food, so this delayed gastric emptying or nausea may be a reason you choose to deprescribe or taper this medication earlier versus later. All of these but one are injectable. They are not insulin, but they are injectable. Some of the injectable options are administered daily, Some are administered twice daily and other are administered just once weekly. Semaglutide does come in a daily oral formulation, but must be taken on an empty stomach at least 30 minutes before food, drink, or other medications while standing or sitting, not laying down. So it's a little more complex for that oral formulation. It is important to know which formulation your patient's on so that you know how often they are taking this as you are designing a deprescribing plan. I would recommend weekly frequency for assessing a patient's blood sugar monitoring from their home monitoring for a non-intensive therapeutic lifestyle program. These medications will have their largest impact on lowering postprandial glucose levels and a lesser effect on fasting glucose levels. Abrupt discontinuation may be necessary if the patient is struggling with the gastrointestinal side effects. Another reason for abrupt discontinuation of these medications is that many of the injectable options are formulated in a single dose pen design without the ability to take a partial dose. Others have dosing options but are limited to 2 to 3 options only. There's just not a lot of options for flexibility in tapering doses with this class of medication without prescribing a new strength. Some benefits of this medication, which may lead to you continuing this or delaying deprescribing, is that some have been approved by the FDA for an additional indication, which is to reduce the risk of major adverse cardiovascular events, including cardiovascular death, non-fatal myocardial infarction, and non-fatal stroke in adults with type 2 diabetes. We know in lifestyle medicine that intensive lifestyle treatments can also lower cardiovascular risk, but patients with more significant cardiovascular risk or those making more moderate lifestyle changes could benefit from continuing this medication due to the additional cardiovascular protection that this class may provide. There's a new class of medication that was approved by the FDA in May of 2022 as this course was being finalized. There is only one medication at this time available in the U.S. market under this new class, with more expected in the future. The side effect profile and contraindications are similar to the GLP-1 agonists, and it would appear the discontinuation profile will also be very similar. However, this medication at the time of the recording does not have the indication as of yet for cardiovascular risk reduction. This class is very similar to the GLP-1 agonist class, but acts as a single molecule to bind and activate both the glucose-dependent insulotropic polypeptide, also known as GIP, along with the glucagon-like peptide 1, also known as GLP-1, receptors to improve glucose control. GIP is one of the 2 incretin hormones, along with GLP-1, that have diverse metabolic roles. Our next category is the sodium glucose cotransport 2, also known as SGLT2 inhibitors. So here are the current commercially available products on the screen with the doses that are currently commercially available.
As we look at the discontinuation profile for this class of medication, it is categorized as low risk for hypoglycemia when used as monotherapy. However, there can be an increased risk for hypoglycemia when used with sulfonylureas or insulin. There have also been rare reports of diabetic ketoacidosis with use of this medication, and so this medication would not be recommended for use in patients who have DKA, although, again, this has been rare in patients with type 2 diabetes. I would recommend weekly assessments of patients' self-monitoring.
Our next category is the sodium glucose cotransport 2, also known as SGLT2 inhibitors. So here are the current commercially available products on the screen with the doses that are currently commercially available.
As we look at the discontinuation profile for this class of medication, it is categorized as low risk for hypoglycemia when used as monotherapy. However, there can be an increased risk for hypoglycemia when used with sulfonylureas or insulin. There have also been rare reports of diabetic ketoacidosis with use of this medication, and so this medication would not be recommended for use in patients who have DKA, although, again, this has been rare in patients with type 2 diabetes. I would recommend weekly assessments of patients' self-monitoring glucose data for the outpatient in a non-intensive therapeutic lifestyle program. The dose frequency for all of these medications in this class is once daily, and they are all oral medications. As far as adverse reactions impacting lifestyle change, you do need to be cautious of hypotension and dizziness, as these medications can contribute to blood pressure lowering due to their mechanism of action. Patients may also experience volume depletion with this medication class. Be sure you are educating your patients on the symptoms of hypotension and that they are monitoring their blood pressures routinely while tapering on or off of this medication class. Also educate patients to drink plenty of water while taking these type of medications. There is an increased risk for UTI and yeast infections with this medication. My experience is that this happens more frequently in patients with a history of frequent UTI or yeast infection that have uncontrolled hyperglycemia while on this medication, as hyperglycemia presents an additional risk factor for UTI. Other risks with this class include a risk of increased LDL levels and a risk of Fournier's gangrene. And with just canagliflozin, there can be a risk of bone fracture. The medications in this class were designed to lower glucose levels, but clinical trials uncovered unexpected cardiovascular and renal benefits. The ADA now recommends in patients with type 2 diabetes and established multiple ASCVD risk factors or diabetic kidney disease that SGLT2 inhibitors with demonstrated cardiovascular benefit are recommended to reduce the risk of MACE annualization. Also recommended is for patients with type 2 diabetes and established heart failure with preserved ejection fraction. An SGLT2 inhibitor with proven benefit in this patient population is recommended to reduce the risk of worsening heart failure, to reduce the risk of hospitalizations for heart failure, and to reduce the risk of cardiovascular death. If deprescribing, an abrupt discontinuation may be necessary due to the high cost of this medication and limited strengths available for these medications. You could consider a gradual taper to lower a dose of glucose. Self-monitoring results indicate a need for continued glucose control, or if you're wanting to retain the medication for the cardiovascular or renal benefits. You will need to assess the benefit risk of these additional cardiovascular and renal benefits for this class of medication when determining if it would be discontinued or continued with lifestyle treatment, keeping in mind that intensive lifestyle changes could also provide cardiovascular and renal benefits. You may also choose to continue this medication and stop other diabetes medications if you have a patient more interested in reducing the number of tablets or pills that they have to take each day over the cost of the medication. Since this medication class can also help lower blood pressure along with glucose, and it's only taken once a day, you could choose to discontinue other medications that either require multiple tablets each day, or you could choose to discontinue a blood pressure medicine with a different diabetes medication and continue the SGLT2 medication, as it would lower the patient's daily pill burden, which could help keep them motivated for increasing or sustaining lifestyle changes.
Next class that we have to talk about is the dipeptidylpeptidase 4, DPP4 inhibitors. So these are the currently commercially available products and the strengths that they are available. So when you look at these medications, really not much of a risk for low blood sugar. It's low when used as monotherapy. So as far as gastrointestinal, these medications don't really cause any of the nausea or the vomiting or the diarrhea that we've seen with some of the other medications in this class, but they can slow the gastric emptying. So that could be an inhibitor to the lifestyle changes and getting that volume of food in. These can have a high cost. They are oral, so fairly easy to take. They're once a day. I would recommend weekly assessment of the patient's self-monitoring of their blood sugar if you're looking at this from an outpatient, non-intensive therapeutic change scenario. So one of the things to consider with this class of medications, though, is it is less effective in glucose lowering. So if you're looking at the medications and stopping a medication that's probably not contributing as much to glucose lowering, this would be one of the classes to start with. You could consider the abrupt discontinuation, because really the lower strengths of this medication are not intended or not commercially available to be used as initial doses, but they're rather available in the marketplace for patients that need a lower dose due to renal dysfunction. So the lower doses are intended for dosing in renal dysfunction, not to slowly start and taper up a dose when you're initiating treatment. So there really would not be a need to taper down off of these medications. With a couple of medications in this class, it would be the saxagliptin and linagliptin. It would be important to note if a patient is on any inhibitors or inducers of this 3A4 system, because that could impact the levels of these medications that the patient might be on and the pharmacodynamic responses. So just be aware and maybe do some consultation with a pharmacist if needed to decipher if the interactions between these medications could be affecting the rate of taper that you need to be making with these medications. Our next class would be the alpha glucosidase or AG inhibitors. So not used as often in practice, but still important to go over because we may see patients on these medications. So when we look at the low blood sugar risk, this is a low risk when used as monotherapy, but similar to several of the other oral medications, gastrointestinal will be the largest adverse drug reaction that could affect lifestyle change. And with this one, it's going to be more flatulence and diarrhea that your patients may experience. The cost on these we have as medium because they are available generically, but the generic versions of these medications are still a little more costly than some of the generic alternatives for the other classes of medications. Fairly easy as far as being oral, but the obstacle for patients is going to come with the dosing frequency requiring 3 times a day dosing with each meal. So like the previous class, this class is also less effective in glucose lowering capabilities. That may be a reason to choose it as one of the first medications to discontinue or taper. Also, you've got a risk for patients with medication non-adherence with this TID dosing. So it'd be important to evaluate right up front with your patients if they're even truly really taking this medication as prescribed prior to initiation of their lifestyle treatment. Are they really taking this 3 times a day? I would ascertain that for many of your patients that it may be once a day or twice a day if you're lucky that they're actually getting this medication in. So that can impact your decision as well. So if a patient is adherent, you might want to consider reducing the frequency rather than the dose to reduce the cost to the patient. So what you could do is, especially if you're looking at, an immersion center, you might be seeing a patient that's on an intermittent fast with perhaps only getting in 2 meals a day. So you could either reduce it from 3 times a day to just the 2 meals they're having a day, or you can move the dose with each meal to just 1 dose with the largest meal of the day if you don't feel the need to move forward with an abrupt discontinuation of this medication. You could also prescribe a lower strength at the 3 times a day frequency if there are no cost or adherence barriers for the patients, and the self-monitoring identifies the need for consistent dosing throughout the day. So our TZDs are our next category of medications. You can see the ones that are commercially available in the marketplace and the strengths that are commercially available at this time. Again, this class of medication is used less in clinical practice now that we have some newer options available, but still important to cover. Low risk when used as monotherapy for low blood sugar, but as far as little different here when we're looking at the adverse drug reactions affecting lifestyle change, we're looking at weight gain, fluid retention, and edema as some of the side effects caused by these medications. So this can inhibit lifestyle change in your efforts to reduce a patient's weight, for instance, if the patient remains on this medication. Cost of these medications is low. They are available generically. They're taken once a day orally, so not super complex for a patient to have to take. But again, because of the side effects, it could be one of the first medications you want to discontinue from the patient's profile. Would recommend for that outpatient, non-intensive therapeutic change scenario, at least a weekly assessment of the patient's blood sugars in your tapering plan. So when we look at this, I would consider abrupt discontinuation despite the lower medication cost, just because of the lower effectiveness and the potential for the fluid retention and weight gain when looking at this class of medication. Also, your taper can be achieved with prescribing a lower dosage if needed, if you feel like there is a need for additional medication to control glucose levels through the assessment of the patient's self-monitoring blood glucose results. Our next class of oral medications is one of our oldest classes, sulfonylureas. So the first generations are no longer listed as treatment options for type 2 diabetes by the American Diabetes Association. So we are going to be talking more in context of the second generation sulfonylureas today. So these are the products available on the market with the strengths that are available in the marketplace as well. So when we look at this class of medication, there is a moderate risk for low blood sugar with these medications. So definitely for the oral medications, this is one of the higher risk factors for causing a low blood sugar. And some of the adverse drug reactions affecting lifestyle change we need to worry about are weight gain and that risk for low blood sugar. These are oral medications, can be taken once to twice daily, so not extremely complex for a patient to take. Low cost, they've been on the market the longest, and so generic available for nearly every brand on the market. And if we are looking at assessment here, I would recommend at least weekly. So I do want to bring up a couple things, though, when we're looking at the considerations for reducing the dose. The American Association of Clinical Endocrinologists consider this medication category as the last line option, and for a few reasons. Due to the lack of durability, the plateau of efficacy at doses lower than maximum approved dose, the modest weight gain, and the risk of serious hypoglycemia that can occur with this class of medication. And so I've broken this down a little bit for you in the next section. The longer the patient's been on this medication, somewhere between 4 and 10-year mark, in practice, I have seen that there's this loss of efficacy that can happen with prolonged use. That's mainly related to the acceleration of beta cell apoptosis that can occur, whereas these medications are working on the beta cell to consistently press the beta cell to release more insulin. And so you just see this acceleration of the natural progression of the beta cell apoptosis that can happen with the progression of type 2 diabetes. So greater than 4 years, consider abrupt discontinuation. If it's been less than 4 years, you could consider in that outpatient, non-intensive therapeutic change, and with a patient that's not as aggressively engaged in lifestyle change, maybe a 50% reduction weekly as you're following and assessing the self-monitoring blood glucose results as your guide in your tapering of this medication class. Our last oral class of medications discussed today are the meglitinides. So you can see the products that are currently available in the marketplace and the dosages that are available. In our discontinuation profile for this class, there is a moderate risk, like the sulfonylureas, for causing a low blood sugar. You also have that risk of weight gain and hypoglycemia, similar to the sulfonylurea profile. These are oral medications that are taken 3 times a day with each meal. Again, this becomes a little more complex, and the risk for patient non-adherence. So again, I'm going to advise that as you're starting to get a history on this patient, as you're making a plan for lifestyle change treatment and for tapering of the medication, you want to consider if the patient's actually taking the medication as prescribed. So you may be able to discontinue or taper this medication more quickly if the patient's not actually taking the medication at the doses prescribed. So when we look at this, it is less effective when compared to other diabetes medication classes. You do have that risk for medication non-adherence with that 3 times a day dosing. And like we talked about earlier with another class, you can consider reducing the frequency rather than the dose to reduce the cost to patients associated with the prescribing that new strength. So again, if you've got a patient that's doing an intermittent fast, consider reducing it to 2 doses a day. If they're doing 2 meals a day, you could even look at moving just to 1 dose with the largest meal of the day or the earliest meal of the day in that intermittent fast. You can, if the blood glucose self-monitoring results identify a need, you could be looking at prescribing a lower dose at that 3 times a day frequency if needed. Next, we're going to move into our mealtime or correctional insulin category. So just some things to consider here for mealtime or correctional insulin. You have rapid acting and short acting. And there are some characteristic changes. So your rapid acting options are going to have an onset of action of about 15 minutes after injection, and they're going to peak about an hour after. And their duration is going to be about 2 to 4 hours after use, whereas your short acting insulin takes a little bit longer. The onset's 30 minutes. The peak's going to last a little bit longer. So instead of 1 hour, it's going to be 2 to 3. And so the duration, again, coinciding, works a little bit longer. So the duration is going to be for 3 to 6 hours as compared to that 2 to 4 hour mark. So some of the things to consider with mealtime or correctional insulin is next we're going to move in about an hour after. And their duration is going to be about 2 to 4 hours after use, whereas your short acting insulin takes a little bit longer. The onset's 30 minutes. The peak's going to last a little bit longer. So instead of 1 hour, it's going to be 2 to 3. And so the duration, again, coinciding, works a little bit longer. So the duration is going to be for 3 to 6 hours as compared to that 2 to 4 hour mark. So some of the things to consider with mealtime or correctional insulin is one, that high risk of low blood sugar. So we definitely want to be more aggressive in these patients in getting this medication tapered right at the start of lifestyle treatment. So you also want to consider some of the adverse drug reactions that affect lifestyle change, such as weight gain, that risk for low blood sugar, and increased appetite when you start to add insulins. So the cost can also be very prohibitive for patients, can be quite high. It is an injectable medication, so for some patients, you might find that their goal is going to just be to get off those injectable medications first, especially if their comfort level with injections or needles is not very high. The assessment in an outpatient, non-intensive lifestyle change should be done at least every 2 to 3 days. Should not really go out for that weekly assessment because you need to be making more timely assessments and adjustments with patients on insulin because that risk of hypoglycemia is so much higher in this population of patients. You're going to consider that there could be some patients right away that are not adherent to their mealtime or correctional insulin, either because of a complexity of a correctional scale or because of the multiple daily doses of that 3 times a day with each meal complexity to the dose that might be occurring. Some dose reduction considerations. So reductions in that mealtime correctional insulin should be directed by your postprandial self-monitor blood sugar results. And you could see some changes in a patient's insulin sensitivity. So any episodes of hypoglycemia should be followed by immediate dose reductions of insulin. So again, important in your patient education plan to make sure the patients are telling you, or at least know to tell you, or how to report if they do have a low blood sugar. So if it's outside of that 2 to 3 day assessment period, if it's only 1 day after you've just talked to them, that they know to report that right away for some kind of adjustment to their dose. You want to make sure that you're considering calculating a new insulin sensitivity factor every couple of days. I've seen patients in immersion centers, like a 3-day weekend immersion program, come out and have their insulin sensitivity changed quite dramatically in just a weekend program. So it is important to be looking at that every few days. And if you are in an intensive treatment center and you're doing an intensive treatment or immersion center, you actually could consider a 30 to 50% reduction on the first day. And then you can evaluate the insulin sensitivity factor after that first full day of coverage. And it's probably better to put a patient on a correctional scale at that point as compared to a very structured mealtime standard dose. A patient's adherence with the medication, again, and the glucose self-monitoring prior to lifestyle treatment are very important considerations in choosing whether or not to discontinue. In our clinic, we may discontinue this correctional insulin as one of our first insulins, just because one, patients are likely not adherent with the medication 3 times a day dosing or those complex correctional scales, but also because it's not safe for a patient to be on mealtime or correctional insulin if they are not monitoring their blood sugar at least 3 to 4 times a day. So from a safety factor, sometimes we will discontinue this medication as one of the first and then just monitor for needing to bring it back or add another medication in its place if a patient's blood sugars do start to rise. Our last category of medications to discuss is our basal insulin, so our long-acting insulins. Again, you can have a varying onset, peak, and duration depending on if you're looking at intermediate, the long-acting, or this new category of ultra-long-acting basal insulins. So these are the products currently on the market. And I will say for some of these devices, you will want to consider if the patient has a vial versus a pen, because their ability to measure and adjust the dose could be impacted by that. And with most of the pens, they do go by 1 unit increments. But there are some newer devices like the Toujeo Max Solastar pen that actually adjust the dose in 2 unit increments only. So you could only adjust the dose in units of 2 at this time. So on the discontinuation profile for the basal insulins, again, insulin is a higher risk for causing a low blood sugar. And just like with the short-acting insulins, our adverse drug reactions will be weight gain, low blood sugar risk, and increased appetite. The cost, again, is high. The route of administration is that subcutaneous injection. So again, consider for patients that may have one of their goals or drivers for lifestyle change may be to reduce their injectable medications. The assessment is the same that is going to be recommended here with that outpatient, non-intensive therapeutic change is going to be a minimum of every 2 to 3 days. So again, will not be like a weekly assessment. You need to be assessing every 2 to 3 days. And for these basal insulins, most of the patients you're going to see on once daily injections, but you may see some patients either on the higher dosages or the intermittent basal insulins that are on twice daily injections as far as administration times. Our dose reduction considerations would be reductions in basal insulin should be directed by your fasting blood sugar results. As you're reviewing a patient's self-monitor blood sugar reports or blood glucose reports, you should be looking at their fasting to drive your decisions for the discontinuation of the basal insulin. Just like with the short-acting insulins, any episodes of hypoglycemia should be followed by dose reductions of the insulin. You may be used to seeing patients on those correctional scales for the short-acting insulin, but typically we're used to seeing patients with basal insulins on a routine daily dose. But it can be beneficial to give your patients a basal dose adjustment scale that's driven from their fasting, self-monitor blood glucose results each day. This way, especially if you're going into a weekend or a situation where a patient may not be able to get a hold of the clinic or yourself for a day or two, at least this is going to be giving the patient some kind of direction on how to adjust the dose if their blood sugar fasting results do start to fall so that they can quickly adjust, but still follow up with the need to contact the clinic to make them aware of any low blood sugar results that do occur. I would consider for an intensive lifestyle treatment or immersion center to reduce the dose on day 1 by at least 30% proactively or preventatively, and then you can make further adjustment based on the next day or day 2's fasting blood glucose result. Again, you'll need to consider patient adherence with the medication and the glucose monitoring. Again, it would not be safe to continue insulin in a patient who is not self-monitoring while they're in lifestyle change, because the rate at which their blood sugars could be dropping could be rapid and dramatic.
The third objective is to describe subjective and objective measures to be included in the assessment and planning of medication deprescribing.
We have provided an example of a tapering protocol for basal insulin for patients involved in intensive lifestyle change. Fasting glucose levels are used to determine basal insulin efficacy and the need to adjust dosage, which you may have experienced when increasing basal insulin doses in traditional medicine practice. You can use basal glucose levels to deprescribe in a similar fashion. This is based upon our own clinical experience and has no evidence to support these recommendations. For a patient initiating intensive lifestyle change, the need to deprescribe medications can occur quickly, and to prevent hypoglycemic episodes, you may want to proactively reduce basal insulin doses to prevent this from occurring. If your patient's fasting blood sugar is greater than 250 milligrams per deciliter as the patient is beginning their intensive lifestyle change, you could continue the patient's current dose of insulin due to this level of hyperglycemia. However, it would be advisable to taper down the basal insulin for lower levels of fasting blood sugar until you can better assess the impact of the intensive lifestyle change on the patient's glucose levels. We've included what to have in your education for the patient in this example to ensure your patient knows how to adjust the insulin, how to report any changes they may have made on their own to the daily dose, and what to do if they're experiencing a low glucose level or symptoms of hypoglycemia. Providing this level of planning and education is important from a safety perspective.
Another example, patient education for a basal insulin adjustment plan example that we've used in our clinic. So we talked before about patients may not be used to, and you as a clinician may not be used to giving out a scale for adjustment with a basal insulin, but it can be helpful for a patient that needs to quickly be adjusting day by day the dose of the basal insulin with an intensive or a quick adoption of a lifestyle treatment program. So you can see here, it's based on the morning blood glucose result and how they are adjusting their dose of the insulin down each day. This provides the patient with some immediate feedback on how to adjust the dose based upon their blood sugar levels. It helps prevent episodes of hypoglycemia by making those quick daily adjustments. But I would also make sure that you add on this education plan what to do, how to treat a blood glucose level less than 70 if it does occur, and not just how to treat it, but how they should then go about reporting that if that does occur. And you can see in here, our example, we've got, if they've got a blood glucose less than 70, how to treat it and then how to report it. But also if they have a blood glucose of less than 100 at bedtime. So bedtime is a real concern that we don't want our patients going to bed with a blood glucose less than 100 because the risk for nocturnal hypoglycemia would be even greater.
The last objective that we are discussing today is identifying the type and frequency of follow-up monitoring and patient interaction options.
We have provided an example
Subjective measures in deprescribing include things like medication tolerance. We just discussed adverse events, sensitivities, and other intolerances in depth in the slides above. So hopefully those tables will be a good reference for you. Patient values and goals are also important as a subjective measure in deprescribing. Cost is a significant reason many patients will not take certain medications. This happens frequently to me in the clinic when I want to prescribe something, but insurance won't cover it. And some of the costs of these medications can be several hundred to over $1,000 each month. Next is patient preference. Some patients want to avoid injections at all costs. Other patients would prefer to do as few medications as possible. Working with both of those preferences could help engage the patient and allow for further deprescribing. Lastly, as we've discussed throughout this presentation, patient engagement is also important. Are patients using their medications as prescribed? Are they missing doses? And how is their blood sugar controlled? Is their A1C within a target range, or is it still elevated? Our objective measures for deprescribing again include the medication cost, and this may be what's covered for them and what isn't. Another hindrance in medication deprescribing that needs to be addressed is how much of a supply does a patient currently have? Have they just gotten a new refill with all of their insulin? Or do they have a new box of pens? If patients have a lot of medications at home, they may prefer to finish those out before switching or trying to something new. Or they may choose to taper off of what they have a smaller supply of first, and then off of another medication. Self-monitoring values and trends is an extremely important part in deprescribing. We are going to discuss this more in the following slides, but patients who are adherent with checking their blood sugars and taking their medications regularly are usually a lot easier to treat than those who are not checking regularly and on medications that have a risk of hypoglycemia. So the biggest take-home point here is that hypoglycemia is much more dangerous than letting someone's blood sugars run higher. And so finding ways to monitor for this is very important. Other objective measures in deprescribing include a patient's vitals and lab work. Blood pressure readings are important as a patient's blood pressure may go down as they make lifestyle changes with weight loss and with the types of food eaten. And lab work will also improve, sometimes very rapidly. Fasting blood sugar could improve within 24 to 48 hours. Hemoglobin A1C values could change rapidly as well. And within about 1 month's time, you could see a significant trend either downwards or upwards. This would be about 50% of what it will change total over the next 3 months. Microalbuminuria can improve or worsen. Creatinine, BUN, and liver function tests are also other important markers that you may wish to check at the start of lifestyle change, about 1 month into it, and then every 3 to 6 months following. Denise and I wanted to walk you through a case presentation. Part 1 of this presentation focuses on a 42-year-old male who's newly been enrolled in a PIVO class, previously known as CHIP. The patient's goals are to reduce his daily pill burden. He's highly engaged in making lifestyle changes. He has no history of cardiovascular disease or renal disease. The patient's weight is 162 pounds. His A1C is 7.9. His total cholesterol is 160. His LDL is 83. HDL is 49. Triglycerides are 118. Creatinine and microalbumin are normal. His average blood sugar is 180 with his self-monitoring, and his blood pressure is in good control at 118/78. He does have a family history of early cardiac disease, with a father having a heart attack at age 49. His current medications include empagliflozin metformin, 1,000 milligrams of extended release once daily, linagliptin, 5 milligrams once daily, valsartan 40 milligrams once daily, and rosuvastatin 10 milligrams once daily. Our first question is, what medication changes would you make? Would you change the combination medication empagliflozin metformin 1,000 milligrams extended release once daily to the individual components of empagliflozin and metformin to prepare for medication deprescribing? Option A is to change, and option B is keep the same. In this scenario, we feel like the best option is answer B. Keep the combination medication the same, as the patient's goal is to daily reduce pill burden. So changing the combination to do separate medications would be adding another pill, and that could be demotivating for your patient. Next question, are there any changes you would consider making prior to his first PIVO class, given the patient's most recent self-monitoring results and labs? You can choose all that apply here. Option A is reduce his valsartan from 40 to 20 milligrams once daily to provide motivation for your patient. Or option B, reducing rosuvastatin from 10 milligrams once daily to 5 milligrams once daily. Here, both answers are appropriate. As the patient is engaged in making lifestyle changes, his blood pressure is currently in good control under 120/80, and his goal is to reduce pill burden. Reducing the statin could encourage exercise and reduce muscle aches and joint pain, and reducing his blood pressure medication could also be appropriate. He will be closely monitored in this intensive outpatient program, so if medication needs to be added back, it easily can. This flow chart discusses deprescribing diabetes medications at the initiation of a lifestyle change program. The first scenario that we're going to look at is a highly engaged patient who's taking medications as prescribed, who is either entering an intensive program or a non-intensive therapeutic lifestyle change program. We'll start with a scenario to the left. We've got a highly engaged patient taking medications who's starting an intensive lifestyle medicine program, who has an A1C that's between 7 and 8 or below. A quick note here. We left the A1C goal between 7 or 8 or below because the target range really depends on the patient. Most patients, a target range of less than 6.5 is appropriate, especially for those who've had a short duration of type 2 diabetes, or if they are treated with lifestyle or metformin alone. However, patients who are at risk of hypoglycemia, those with a limited life expectancy, advanced chronic conditions, or who have long-standing diabetes, or who have been very difficult to control, their A1C goal may just be less than 8. So that's why you'll see a range here. Going back to our scenario, where we have the highly engaged patient starting the intensive therapeutic lifestyle change program, who is starting with an A1C that is less than 8. When they begin their intensive program, All oral hypoglycemic medications should be discontinued, and all basal and mealtime insulins should be reduced between 30 and 50%. Their blood sugars should be monitored daily. If they are on mealtime insulin, their blood sugar should be checked regularly before and after a meal. And if they are on any hypoglycemic medicines, they should have their blood sugar checked before bed. All the blood glucose logs and vitals should be checked every 2 to 3 days if they're in a residential program, or every 5 to 7 days if in an intensive outpatient program. Medication changes should be based off of those logs and based off of patient symptoms. In our second scenario, we have a highly engaged patient who's in an intensive therapeutic lifestyle change program, but they are starting with a hemoglobin A1C greater than 8. In this case, you'll want to consider discontinuing some or all oral hypoglycemic medications. However, since they are uncontrolled, you may not want to stop them completely like you did in the well-controlled patient. Basal and mealtime insulin should be decreased by 30%. And again, blood sugar should be monitored daily. If they are on mealtime insulin, blood sugar should be checked before and after. And if on hypoglycemics, blood sugar should be checked before bed. Again, blood sugar logs and vitals should be checked every 2 to 3 days if it's a residential program, or 5 to 7 days if they're in an outpatient program. And medications should again be adjusted based off of those logs and the patient's symptoms. Moving to the right, if we have a patient who's highly engaged and they're in a non-intensive therapeutic lifestyle change program, if their A1C is less than 8, their fasting blood sugar should be monitored daily if they're on insulins, or 2 to 3 times a week if they are only on oral medicines. If they are on mealtime insulin, their blood sugar should be checked before and after. And if on any hypoglycemic medicines, their blood sugar should also be checked before bed. Blood sugar logs and vitals should be reviewed every 4 weeks if they're making moderate to large changes, or every 3 to 6 months if they're making small to moderate changes. Patients should be properly educated about hypoglycemia and when to contact the clinic. If we have a highly engaged patient who's in a therapeutic lifestyle change program that's not intensive, and they're starting with an A1C that's greater than 8, again, if they're on insulin, their blood sugar should be checked daily, or 2 to 3 times a week if they are only on oral diabetes medications. If they're on mealtime insulin, their blood sugar should be checked before and after. And if on hypoglycemic medicines, blood sugar should be checked before bed. Their blood sugar logs and vitals should be checked every 4 weeks if they're making moderate to large changes, or every 3 months if making small to moderate changes. Patients, again, should be properly educated about hypoglycemia and when to contact the clinic. Further reducing medications should be considered if a patient's blood sugar is 100 to 120 or less, if their peak postprandial blood glucose is between 140 and 160 or less, if their blood sugar at night is less than 100, or if they have any blood glucose readings less than 70. This flow chart is looking at deprescribing diabetes medications at the initial lifestyle change in patients who have low engagement and are not taking medications as prescribed. For a patient who has low engagement and is not taking medications as prescribed, and they're starting an intensive therapeutic lifestyle change program, if their A1C is less than 8 and it's unclear how much medication the patient has been taking, you may want to consider discontinuing all oral hypoglycemic medications and insulins. Since they're an intensive program, they'll be monitored closely, and so you can always restart medications at 50% if their fasting blood sugars are above 200 for more than 3 days. Their blood sugars should be monitored daily, and if they're on mealtime insulin, you should regularly check the pre- and postprandial blood glucoses. If any hypoglycemic medications were continued, their blood sugar should be checked at night, and blood sugar logs and vitals should be checked every 2 to 3 days. It's residential, every 5 to 7 days if outpatient. Patients with low engagement who are involved in lifestyle changes are not good candidates for at-home insulin tapering scales. For a patient who has low engagement and not taking medications as prescribed, who's starting an intensive program with an A1C of greater than 8, again, you'll want to consider stopping all medications at the start of the program if they cause hypoglycemia, such as insulin or phenylureas, with the knowledge that you can restart them as needed. Their blood sugars should be monitored similarly to those with a controlled A1C. And based off their blood glucose logs and vitals and their symptoms, their medication should be adjusted. Looking at a patient who has low engagement, who's not taking medications as prescribed, and in a non-intensive lifestyle change program, who's starting with a well-controlled A1C, somewhere between 7 and 8 or below, and if adherence is unclear, again, consider stopping all hypoglycemic medications. And if the patient is on a complicated insulin regimen, consider simplifying that to a basal insulin with a GLP-1, an SGLT2, and metformin. Their blood sugar should be monitored daily if on insulin or 2 to 3 times a week if only on oral diabetic medications. With mealtime insulins, they should have blood sugars checked before and after. And if on any hypoglycemic medicines, their blood sugar should be checked before bed. The blood sugar logs and vitals should be monitored every 4 weeks if they're making moderate to large changes, and every 3 to 6 months if they're making small to moderate changes. Medication should be adjusted according to those logs and patient symptoms. Again, they should be properly educated about hypoglycemia and when to contact the clinic. Encourage group activities here and/or other condition management programs to try to help improve engagement and troubleshoot causes for not taking medications as prescribed. For a patient with a low engagement who's starting a non-intensive program, whose A1C is uncontrolled, greater than 8, all of the same rules apply. Their medications will be reduced the least, and until the patient is further engaged in taking medications as prescribed or making lifestyle changes, they may follow a more traditional medication management regimen. Consider reducing all diabetic medications further while monitoring if fasting blood glucose is between 100 to 120 or below, a peak postprandial blood glucose of 140 to 160 or below, blood sugar at night is less than 100, or any blood glucose readings less than 70. Returning to our patient case, we have our 42-year-old male who's now at the end of his 4th week of the Pivio class. He has lost 9.2 pounds. He has had no low blood glucose readings. His current medications include the empagliflozin metformin 1000 milligrams extended release, the linagliptin 5 milligrams once daily, the reduced valsartan now 20 milligrams once daily, and the reduced rosuvastatin 5 milligrams once daily. His average blood glucose is now 150 milligrams, and his blood pressure on the lower amount of blood pressure medicine is now 117/75. So the question is, what medication changes would you make next? We'll start with his diabetes medications. He has been very excited about his changes and is asking to stop more medications if possible. His CGM shows his fasting blood glucose this morning was 124. So what would you do? Would you stop the empagliflozin metformin? Would you stop the linagliptin? Would you stop both or continue both? In this scenario, the best answer is B. Stop the linagliptin 5 milligrams once daily. His average fasting blood glucose has been trending down, and he's in an intensive program. If he was in a non-intensive program, it would be reasonable to wait till the average fasting blood glucose was between 100 and 120 before reducing medications. However, here, where he is in that intensive outpatient program, he'll be monitored closely. It's reasonable to stop the linagliptin, as DPP-4 inhibitors have the lowest efficacy, and stopping the linagliptin would be a source of motivation to sustain and advance lifestyle changes. Metformin is usually the last to be discontinued because of low cost and relatively good safety profile. Next question. Are there any other changes you would make to his medications? Would you stop his valsartan 20 milligrams once daily, statin 5 milligrams once daily, stop both, or continue both? In this scenario, we believe the best answer is A. This patient's blood pressure has lowered with lifestyle changes, even in light of the previous dose reduction. Discontinuing the valsartan with instructions to have the patient monitor his blood pressure daily with close follow-up and report it back if he begins to trend above 140/90 millimeters of pressure is a safe way to help him meet his goals of reducing his medicines further. Rosuvastatin and similar high-dose statins may have benefits for patients with diabetes beyond their cholesterol lowering. Continuing a low-dose statin here is reasonable. However, to note, some providers may choose to stop it because of the side effects of muscle aches and joint pain that may inhibit patients' exercise and engagement in physical movement during this program.
When Dr. Scholl and I worked in clinic together, we would use this glucose self-monitoring frequency chart to help guide patients and how often they should be monitoring their blood sugar. So we had minimum testing frequencies and then some optional testing times. And I will say with lifestyle medicine treatment that we would also be adding in there, besides the meal pairs and the activity pairs and the bedtime, we'd also be educating patients to be watching for times of stress or nights without a good night's rest so that they would be watching to see how their blood sugar levels could change. But as far as the frequency goes, we would be looking at patients that were not on medications, but were making lifestyle change or involved in lifestyle treatment to reverse their disease. Testing at least once a day, that fasting level every day, but giving them those optional testing times as well. Patients that were on non-insulin medications, except for the sulfonylureas, it would be fasting every day. If the patients were on sulfonylureas, we would also add that bedtime testing as well from a safety perspective because of the risk of hypoglycemia that can happen with sulfonylureas. If a patient was on basal insulin with or without other non-insulin medications, again, we would do fasting and bedtime. Our fasting blood sugar levels would direct our dose of tapering, and our bedtime levels would be assessing the safety of the medication so that we could prevent nocturnal hypoglycemia. As we move on, the premixed insulin combination. So if you have a fixed basal bolus regimen, we'd be looking at before meals and at bedtime as a minimum. And the same with a complex insulin regimen that might have varying doses based upon blood glucose results.
This flowchart looks at blood pressure thresholds and recommendations for treatments in patients initiating lifestyle changes. We are going to look at several ranges of blood pressures and when a patient may need their blood pressure reduced or discontinued. Starting at the left, if a patient is starting lifestyle changes and their blood pressure is less than 100/70 and they're off medications, there's nothing to do here but to monitor and to continue lifestyle changes. They're in good control. However, if they're on medications and their blood pressure is less than 100/70, consider decreasing or discontinuing a medication, especially if the patient is feeling symptomatic, and monitor the blood pressure 3 to 7 days a week and if they become symptomatic. The next range we'll look at is a blood pressure of 100 to 119/70 to 79. If a patient's off medications and making lifestyle changes, continue to monitor. They're in good control. However, if a patient is on medication, again, consider discontinuing or decreasing the medication, especially if they're in an intensive therapeutic lifestyle change program and low risk for acute cardiovascular events, or if they're having medication side effects. Monitor them every 1 to 3 days and have patients contact you if their blood pressure begins to go over 140/90. The next category is blood pressures of 120 to 139 over 80 to 89. If they're off medication and continuing a lifestyle change program, have them continue this for 3 to 6 months and then follow up. It is helpful if patients keep home logs of their blood pressures so you know where they've been running in between their last visit. If they are on medications, ask how they are taking the medication. Are they missing any doses, or are they taking it daily? Continue the medication regimen as they are not controlled and recommend further lifestyle changes. Have them monitor their blood pressure at home every 1 to 3 days and keep a log to show you at your next follow-up visit. Follow-up should be close, between 3 to 6 months. The next blood pressure range is 140 to 159 over 90 to 99. If a patient is off medication, in addition to starting lifestyle change, initiate medication treatment and have patients monitor every 3 to 7 days and if they are symptomatic. If they are already on medications, ask how they are taking their medications and if they're missing any doses. And also check to see how compliant they are with lifestyle changes. Both medications and lifestyle treatment may need to be intensified. Patients should monitor their blood pressure every 3 to 7 days, and if they are symptomatic, and have close follow-up. In the last category, if a patient's blood pressure is 160/100 and they're off medication, in addition to lifestyle changes, 2 medications demonstrated to reduce cardiovascular events should be initiated. Their blood pressure should be monitored every 3 to 7 days, and if they're feeling symptomatic. If they are already on medications, ask how they're taking their medications and if they are missing doses. Also check to see if they are making lifestyle changes and how intensely they're making lifestyle changes. Both medication treatment and lifestyle treatment may need to be increased. If they're on 3 high blood pressure medications, including a diuretic, and not meeting guidelines, consider adding a mineralocorticoid receptor agonist. And if they're only on 2, considering adding a 3rd medication. Monitor their blood pressure every 3 to 7 days, and if symptomatic, with close follow-up. A quick note here, for patients with diabetes and high blood pressure who have a 10-year risk of heart disease that's greater than 50%, their target blood pressure should be less than 130/80. For patients with diabetes and high blood pressure with a 10-year risk of heart disease that's less than 15%, their blood pressure target should be less than 140/90.
It's also important to teach your patients to adjust medications based upon some symptom self-monitoring, especially for particular categories of medication. We're going to call out here that any patient who is made aware of a whole food plant-based diet or lifestyle change should be counseled on the dangers of making changes without medication adjustment and appropriate follow-up. So as we look at some of the symptoms that patients could self-monitor for, some of it's going to be those adverse drug events that we had discussed previously, such as constipation, diarrhea, or even reflux. So if we're looking at medications used for treating reflux, we might be having the patient monitor how frequently they're having those symptoms if we do an abrupt taper of a medication used to treat reflux. Allergies, sleep, symptoms of hypotension, so lightheadedness upon standing, presyncope or fatigue, and also early symptoms of hypoglycemia. So it's important to educate the patients not only on these symptoms, but how to adjust their medications and taper or deprescribe the medications based upon these self-monitoring of symptoms.
Our third part of the case presentation goes back to our 42-year-old male who's now completed 9 weeks of the Pivio program. He has lost 17 pounds, and he has mentioned he recently felt dizzy with a bit of blurred vision while golfing. He has had no low blood sugar readings, and his current medications include empagliflozin metformin, 1,000 milligrams extended release once daily, and the rosuvastatin 5 milligrams once daily. His A1C has improved from 7.9% to 6.3%. His cholesterol has also improved, and his average blood glucose is now 120 milligrams a deciliter. His blood pressure has continued to remain well controlled at 114/81. So what medication changes would you make to his diabetes medications, if any? Option A is stop the empagliflozin metformin. Option B is continue the empagliflozin and stop the metformin. Or option C is continue the metformin and stop the empagliflozin. The correct answer here is C. Discontinue the empagliflozin since patient is experiencing hypotensive symptoms while golfing. The SGLT2 inhibitors may contribute to lower blood pressure and may be causing hypovolemia. Metformin is usually one of the last diabetes medications to be discontinued after implementing lifestyle change. You would want to consider the patient's cardiovascular risk and history of renal disease, as well as having a shared decision-making with the patient to determine which change would be most appropriate. In this case, he does have a history of early heart disease in his father, but no personal history, and his kidney function is normal. So it is okay to go ahead and stop the SGLT2 inhibitor, empagliflozin.
I have an example here of a patient education plan where a patient is being taught to adjust their proton pump inhibitor medication based upon symptoms, and it has several steps of deprescribing in this example over the course of a few weeks. So the basic information that you want to make sure to include in a patient education plan: the name of the medication. You don't want to assume the patient knows why they're taking the medication or the name of the medication. So many times non-occurrence occurs because a patient doesn't know why they're taking a medication, so they stop taking it. So it's important for them to know that name and that medication use. You'll also want them to know the risks of short-term and long-term medication use. So as an example, with this proton pump inhibitor, it'd be important to make sure the patient knew that long-term risk with these medications included increased risk of fracture of the hip, wrist, and spine. Extended use can also lead to infections, pneumonia, and low magnesium, calcium, or vitamin B12 levels. It's also, though, on the opposite side of that, it's important to explain the dangers of stopping abruptly. So if you start to go through just those long-term risks with a patient, they may just decide to stop taking the medication. So it's also important to explain the dangers of stopping abruptly, especially if they're not currently making or adherent to lifestyle treatment. So this could be an increase in acid production that could occur with rebound reflux if they're not adhering to that lifestyle change that's fixing that underlying cause of the condition. So this example is for someone that is not making lifestyle changes. So as we're looking at this example, don't pay attention so much as to the frequency of how often they're tapering, but more to what should be included in the patient education plan. Symptoms to monitor for and the importance of follow-up assessments by a provider are also important to include in that plan. So in some intensive programs, proton pump inhibitors are actually able to be tapered and discontinued over a course of 3 days. One of the keys to tolerating this abrupt and quick discontinuation and having the acid reflux reduce is implementing a fast starting early in the afternoon or having a very light or minimal dinner.
Patients should follow up with their providers regularly, and providers will be in charge of deprescribing all the medications. A question to ask yourself: is it feasible for patients making aggressive lifestyle changes to follow up only with a provider, as they're often difficult to get into and the visits are shorter and often difficult for patients to get all their questions answered? If the answer to that is no, it's not feasible, then an approach for team-based care is a better choice. And this is almost 100% of the time a good idea. Questions to ask yourself with who would be best on the team to care for patients include: can a nurse or certified diabetes educator be assigned to ensure that a patient is self-monitoring and sharing the results and trends? Is a pharmacist or a nurse trained in advancing diabetes management be a delegate to assess the daily or weekly medication adjustments needed based upon those self-monitoring values and patient symptoms? Can a registered dietitian help by reviewing a patient's nutritional intake and blood glucose logs and helping patients identify opportunities and working with them to overcome barriers as they're making changes and adopting a more whole food plant-based diet? And lastly, how often should the patient be scheduled for provider interaction? We're going to look at that a little bit more on the next slide. There's several types of follow-up that can be done. Patients can meet face-to-face, or provider teams can touch base via telephone, email, portal messaging, or virtual visits. How frequently should these be done? As we discussed before in the flow charts, in residential programs, this can be done daily with little to no effort. Intensive therapeutic lifestyle change programs in the community, weekly or biweekly follow-up may be done. Patients who are making therapeutic lifestyle changes in a less aggressive manner may be followed monthly or every 3 to 6 months. Self-monitoring results will also help determine when a patient should follow up. Any patient who has a blood glucose less than 70 at any time should be followed up with by someone from the care team and likely the physician for deprescribing. Those who have fasting blood glucoses less than 100 for 1 week or blood pressure less than 120/80 for 1 week should also be followed up by the care team and again often by the provider for medication deprescribing. Patients who have symptoms of low blood glucose, but their blood glucose readings are actually not less than 70 may be good candidates for follow-up as well. Often if patients have run high for a long time, when their blood glucose begins to drop, they may feel symptomatic even though they're not truly hypoglycemic. This is a good time for education and reassurance and helping patients know when they truly are hypoglycemic. In summary, we've discussed the side effects of various medication classes that. Thank you